welcome to this Masterclass Explainer. Today we're going to do something a bit different. We are shifting entirely away from just rote memorization. Instead, we're going to fundamentally understand the actual mechanisms and the precise FITT prescriptions for 13 critical clinical conditions. Think about it. If you actually understand why a specific disease limits exercise, whether that's ischemia, pump failure, or airflow limitation, then the specific guidelines and safety rules suddenly make complete sense. We've got a lot of ground to cover today, so let's dive right in. Here is our roadmap for this explainer. First, the clinical exercise blueprint. Then, we'll hit cardiac conditions and rehab, move into vascular and stroke guidelines, tackle obstructive pulmonary diseases, and finally wrap up with complex pulmonary conditions. All right, section 1, cardiac conditions and rehab. To truly understand cardiac rehab, we first need to look at the core mechanisms of coronary artery disease and heart failure. With CAD, you've got cholesterol plaque physically narrowing those vessels. This leads to ischemia, that classic chest pain, simply because the heart muscle can't get enough oxygen during exertion. Heart failure, on the flip side, is pure pump failure. The heart just can't squeeze efficiently. Now, both of these lead to severe exercise intolerance, but we can absolutely combat that. For outpatient rehab, the strict FITT prescription is clear. For aerobic work, you want them going 3 to 5 days a week, starting out at 40 to 60% of their heart rate reserve, and eventually progressing to 80% as tolerated for 20 to 60 minutes a session. Crucially, resistance training isn't just optional, it's explicitly prescribed. We're talking 2 to 3 non-consecutive days a week, doing 1 to 2 sets of 10 to 15 reps, right around 60 to 70% of their 1 rep max. Now, obviously, safety is the absolute priority here. For patients recovering from open heart surgery, you have to ensure strict adherence to early sternal healing precautions. The modern guidance is a concept called move in the tube. This basically means keeping loads within a pain-free, moderate range closer to the core of the body, rather than relying on the old, highly rigid restrictions. And you must, absolutely must, terminate a session immediately if you observe any angina, marked dyspnea, ischemic ECG changes, new dysrhythmias, or an abnormal blood pressure response. No exceptions. So that brings us to a crucial point, a golden rule you need to burn into your brain. It's all about the number 10. You must keep the training heart rate at least 10 beats per minute below the known ischemic threshold for CAD patients, meaning 10 beats below the exact point where ST depression or angina begins. And if you're working with a patient who has a pacemaker or an implantable cardioverter defibrillator, an ICD, you must keep their peak training heart rate at least 10 beats per minute below the device's programmed shock or pacing threshold. You definitely don't want to accidentally trigger an ICD shock during a workout. Now consider the physiological reality of a heart transplant. It's honestly fascinating. When a patient receives a donor heart, that new heart is completely denervated. It has lost its direct autonomic nerve supply. Because it lacks a vagal brake, a transplant patient naturally suffers an elevated resting heart rates. But even more importantly, during exercise, the heart literally cannot speed up through instant nerve signals. Instead, it relies entirely on slowly accumulating blood hormones, like catecholamines, to increase its output. Because of that denervated mechanism, your FITT prescription has to change entirely. Transplant patients absolutely require much longer warm-ups and longer cooldowns to give those hormones time to ramp up and wind down. You also have to ditch heart rate zones and use RPE to gauge intensity. Plus, you need to push resistance training specifically to counter the severe bone and muscle loss caused by their anti-rejection corticosteroids. Contrast this with spontaneous coronary artery dissection, or SCAD, which is a literal tear in the artery wall. For SCAD patients, they require highly conservative aerobic limits, and you must completely avoid the Valsalva maneuver, heavy lifting, or any extreme exertion. Moving right along, let's hit section 2, vascular and stroke guidelines. For peripheral arterial disease, where narrowed leg vessels cause cramping and pain during activity, walking is quite literally your best medicine. It's the absolute primary prescription. We rely on a very exact interval model to purposefully induce moderate ischemic calf pain. You want them hitting about a 3 to 4 out of 5 on the pain scale before having them sit down and rest until the pain fully resolves. And then they get up and repeat it. The specific goal is a workload that brings on mild pain within 5 minutes and moderate pain within 10 minutes, accumulating up to 30 to 45 minutes of total actual walking time. When looking at systemic vascular diagnoses, remember that an ankle brachial index of 0.90 or less indicates PAD, which is then clinically confirmed by a post-exercise drop of more than 20%. Now, alongside that, we have the precise FITT prescription tailored for stroke survivors who are often dealing with hemiparesis or muscle spasticity. For them, aerobic work should be 3 to 5 days a week at a moderate 40 to 70% of heart rate reserve for 20 to 60 minutes. Resistance training should be done 2 to 3 days a week for 1 to 3 sets of 10 to 15 reps, heavily incorporating balance and functional tasks into the routine. What if you're managing postural orthostatic tachycardia syndrome, or POTS? Well, here, the autonomic system fails to prevent a massive heart rate surge of 30 beats per minute or more the second they stand upright. Because of this, making recumbent exercise, like recumbent cycling, rowing, or swimming, the mandatory starting point is absolutely critical. If you don't, you risk exertional syncope or fainting. Over time, you can progress them upright, but this always has to be paired with very careful, active management of their fluid and salt intake. All right, shifting gears to the lungs. Section 3. Obstructive pulmonary diseases. It is absolutely critical to distinguish between traditional asthma and EIB. Asthma is a constant chronic inflammatory baseline in the airways. EIB, which stands for exercise-induced bronchoconstriction, is a temporary, acute narrowing that is strictly triggered by the stress of exercise combined with breathing in cold, dry air. And interestingly, the symptoms actually peak a few minutes after the exercise stops. Clinically, EIB is confirmed by a 10% or greater drop in FEV1 following a vigorous exercise challenge. But here is the most ingenious physiological hack for managing EIB, having the patient perform a 10 to 15-minute vigorous or variable intensity warm-up. Doing this actually creates a physiological refractory period that actively blunts the airway constriction during their main workout. It's a game changer. Now for chronic obstructive pulmonary disease, which encompasses chronic bronchitis and emphysema, these patients suffer terribly from trapped air, severe breathlessness, and significant muscle wasting. The progressive deconditioning is reversed using these exact FITT parameters. Aerobic frequency is 3 to 5 days a week for 20 to 60 minutes. Your specific intensity gauge here isn't heart rate, it's a Borg CR10 dyspnea target of exactly 3 to 6. You also have to lean heavily on resistance training to combat that severe muscle atrophy. For safety, you must strictly stop any testing or activity if their oxygen saturation drops by 5% or if it hits an absolute floor of 85% or lower. Final stretch, Section 4, complex pulmonary conditions. First up is pulmonary arterial hypertension. Because PAH places massive back pressure strain on the right side of the heart, you must exercise extreme caution. These patients have to be closely supervised at low to moderate intensities using short aerobic bouts. You must completely and strictly avoid any high-intensity work, heavy lifting, breath holding, or the Valsalva maneuver. The risk of exertional syncope is just too high. Next, we have interstitial lung disease. This condition physically stiffens and scars the lung tissue into a restrictive pattern. Because their lungs literally cannot expand properly to transfer oxygen into the blood, your primary clinical duty here is rigorously monitoring their predictable, rapid drop in blood oxygen. You'll want to use moderate aerobic and light resistance work, relying heavily on interval approaches and supplemental oxygen to manage their severe dyspnea. For cystic fibrosis, exercise is an absolute lifesaver. It brilliantly aids the mechanical clearing of the thick, sticky mucus that clogs their airways. However, you must fiercely guard against dehydration and heat illness. Why? Because CF patients have an abnormally high rate of sodium loss in their sweat. It's massive. So aggressive hydration and salt replacement are mandatory during their aerobic and resistance sessions. And lastly, if a clot blocks a pulmonary artery, causing a pulmonary embolism, the safety rule is absolute. Listen closely. There is 0 exercise permitted during the acute phase. None. Activity is only resumed gradually once the patient is completely cleared, medically stabilized, and adequately anticoagulated by a physician. To wrap up this dense, high-yield explainer, let's test your newly acquired mastery. Based on everything we've just covered, can you recall the exact diagnostic pulmonary drop for EIB lull? And what is the precise Borg dyspnea target for COPD? Well, if you said a 10% or greater drop in FEV1 for EIB lull and a Borg score of 3 to 6 for COPD, you are spot on. Understanding these underlying physiological mechanisms doesn't just help you memorize FITT guidelines, it fundamentally changes how you treat the human body in motion. So, based on what we've explored today, what outdated exercise prescription are you going to update in your clinic tomorrow?